Good evening, students. Hello, everyone. Good evening, good evening, good evening. Hello, guys. Good evening, all. Good evening. Am I audible and visible? Good evening, guys. Hello, Navya. Hello, Raman. Hello, Rinmai. Am I audible and visible to you all? Good evening, guys. Good evening. Audible, visible, okay, perfect. Good evening, guys. Come on, let us start the class. So we are talking about the topic breathing and exchange of gases. Last class, I think we completed the human respiratory system. After that, we spoke about the respiratory. We started with the mechanism of breathing process, and I told you some basic things about the mechanism of breathing. In mechanism of breathing, we are trying to learn the two process, inspiration and expiration. Mechanism, I will revise a little bit more. Okay, let's quickly revise mechanism of breathing. Okay, Mumbai's King Siddharth sir. Okay. Now, right now in Vijayawada, na? So being Mumbai's King will not help us. Now, mechanism of breathing. So mechanism of breathing, guys, here we are trying to understand inspiration and expiration, inhalation and exhalation. Okay, tell me which is active and which is passive process. Tell me which one is active here, which one is passive. Please tell. Is inspiration active or expiration active? Come on, tell me fast. In the chat box, come on. Quickly, let's revise. I told you already in the last class. Inspiration is active, yes, because you are contracting the muscles here. So this is an active process and this is a passive process. Here the muscles are contracting, here the muscles are relaxing. Okay. Which are the structures which are responsible for inspiration and exhalation? Okay. Muscles involved in breathing. Muscles involved in breathing. Tell me, come on. Muscles involved in breathing, what you will say? Diaphragm and external intercostal muscles. Diaphragm and external intercostal muscles, they are involved in normal quiet breathing, or you can just say normal breathing. So under normal breathing, we are saying we are using diaphragm and external intercostal muscles we are using. Yes. Are we using anything else here? No. Under normal breathing, we are using diaphragm and external intercostal muscles. Now, let's say if we are forcefully breathing, forceful inhalation, forceful exhalation, in forceful breathing, what we are going to use, tell me? As per NCERT says what? In forceful breathing, what we are going to use? Come on, tell me. In forceful breathing, first you will use your abdominal muscles. Yes, we are going to use the abdominal muscles. So abdominal muscle, now pay attention. I want you to pay little attention here. Abdominal muscle will be used for forceful inhalation also and forceful exhalation also. Forceful inhalation also, forceful exhalation also. Abdominal muscles. Next, after abdominal muscles, what I will say? I will say internal intercostal muscles. Internal intercostal muscles, they are on the inside of the rib cage. They are lining the inside of the rib cage. So basically when they contract, internal intercostal vessels, when they contract, they will pull the rib cage in. They will pull the rib cage in, air will be thrown out fast. forcefully the air will be thrown out. So basically when you are shouting, speaking, singing, you are producing sound. To produce sound, you have to push the air, throw the air out through your vocal cords with some force or pressure. Then only you are able to produce sound. So basically what I'm trying to say here is, this is going to be used in forceful expiration. Forceful expiration, to produce sound. See, that's why I have written here quiet breathing, and here I am writing forceful expiration. Yes? Are you getting me, boys and girls? Yes or no? Chalo, next. Or kya? Or kya? See, sometimes in some reference books or some teachers say casually. Casually, we can say that abdominal muscles and intercostal muscles are used in forceful breathing, no problem. But little logic you have to apply. Abdominal muscles will be used for forceful exhalation also, forceful inspiration also. Internal intercostal muscle will be used for forceful expiration. I will tell you one more muscle. One more muscle. Can you help me? One more muscle. When we are forceful breathing, labored breathing, which muscle I am using? Look here. What is this muscle? These are the neck muscles. What muscles? Neck muscles. So can I say neck muscles are also used in forceful breathing? Answer is yes. So I will write neck muscles. I will write neck muscles. Neck muscles like sternocleidomastoid. There is a mastoid process here till your sternum one muscle runs, sternocleidomastoid. Okay, like this one if you are able to see. Okay, little fat I am so you cannot see. But in more ribbed peoples you can see the sternocleidomastoid. The neck muscle can be used. Other muscles are the scalene muscles of the neck. They are also used, but they are used in forceful inspiration. Chest muscle, pectoralis major. While studying the mammary gland, one pectoralis muscle is labeled that in the human reproduction chapter. Pectoralis major, we can also use little bit effort from the pectoralis major, chest, but this is forceful breathing. So I can write neck muscle also, but neck muscle is mostly forceful inspiration. So you will be surprised to know that pectoralis major muscle, latissimus dorsi, the back muscle, the latissimus dorsi, that can be also used in forceful breathing, but at your level, chill. NCERT is saying diaphragm and external intercostal muscle in normal breathing. Okay. Forceful breathing, NCERT is saying abdominal muscle. Little bit you should know little bit about internal intercostal muscle for forceful expiration. Sometimes loosely a statement can be given abdominal muscles and internal intercostal muscle for forceful breathing. Neck muscle, they will mostly not ask you, but I'm just telling you, these are the accessory muscles which can be used. Are we clear? Now let's go to the mechanism. Boys and girls, come on, pay attention. We are talking about inspiration process. Inspiration process is an active process. What you want to do in inspiration? What we want to do in inspiration, we want to draw the atmospheric air inside. So here we need the atmospheric air to be drawn inside. The lungs. Yes. But to take the atmospheric air inside, I need a pressure gradient difference. What do I need, guys, here? I need a pressure gradient difference. Yes or no? Come on. Pressure gradient difference is required. So basically to take the atmospheric air inside, outside atmospheric pressure is 1 atmosphere, some 760 mm of Hg. I cannot change that. Can we manipulate outside atmospheric pressure? No, we cannot. But I can manipulate. I cannot manipulate the atmospheric pressure, but I can manipulate my internal lung pressure and I can make it negative. I can bring the intrapulmonary pressure to negative. Negative means I am talking here, I am bringing my intrapulmonary pressure lower as compared to atmospheric pressure, and the air will rush inside. Yes, yes, Vinuta, abdominal muscle will be used for both inspiration, expiration. Yes, correct. You are saying correct. Now, so for this I need intrapulmonary pressure. I need intrapulmonary pressure to be lower than the atmospheric pressure. Are you getting me, boys and girls? It means I need a negative pressure. What I need a negative pressure. Now tell me, guys, our anatomical setup of the lungs are in such a way that any change in the thoracic volume will be reflected in the lungs, yes or no? If I change the thoracic cage volume, rib cage volume, that will affect the volume and pressure of the lungs, yes or no? Yes. Why it is in such a way? Why it is like that? Can you manipulate your lung volume and pressure directly? Answer me, yes or no? Can you manipulate, alter, change your intrapulmonary pressure or volume directly? Can you manipulate directly your pressure? No. No, you cannot. So you manipulate, the thing can be manipulated. Which thing can be manipulated? Sir, thoracic volume can be manipulated. Sir, when we manipulate the thoracic volume, the pulmonary volume gets manipulated and then the intrapulmonary pressure gets manipulated. So that's how we will manipulate the thoracic cage volume. That will manipulate the pressure in the lungs, and we are going to create a negative pressure with respect to the atmospheric pressure, and the air will rush in. So let us see that how it happens. So how does inspiration starts? Inspiration is initiated by contraction of diaphragm. Yes or no? It is initiated by contraction of diaphragm. When diaphragm contracts, it becomes flattened. When diaphragm contracts, it becomes flattened. Yes. Who gives the signal to diaphragm to contract? Tell me, apply your common sense. Who controls? Where is the rhythm center? Medulla oblongata. Medulla oblongata has the rhythm center. Rhythm center has the inspiratory group of neurons. That neurons will send the signal via phrenic nerve. Via which nerve? Phrenic nerve, that will stimulate your diaphragm. Diaphragm normally dome shape undi. Normally it is a dome shape. But now it will get flattened. Now it will get flattened. It will go down. It will go down. It will flatten. As it flattens, what happens? What is increasing? Thoracic volume increases in the AP axis, anterior-posterior axis. Your diaphragm is going down. Your diaphragm is going down, anterior-posterior axis, anterior-posterior axis, anterior-posterior axis. What is happening? The volume is increasing. So volume increases in AP axis. I can also write longitudinal axis. So sometime examiner may not give you AP axis, they might give you longitudinal axis. So be careful there. But simultaneously when diaphragm is contracting, as the diaphragm is contracting, simultaneously which also starts to contract? Tell me, diaphragm contracts, simultaneously which one is contracting? Which muscle? Come on, which muscle, guys? EICM. External intercostal muscles. They also will receive the signal. External intercostal muscle will also contract. External intercostal muscles. External intercostal muscles are present on the outside of the rib cage or inside of the rib cage. External intercostal muscles are present outside. Now that's why the name external intercostal. Intercostal means between the ribs. Intercostal means in between the ribs. So what is going to happen? Your external intercostal muscle is going to contract. It will pull the rib cage out and up. It will lift the rib cage outwards and upwards. In NCERT, they are writing that external intercostal muscle contracts and lift the rib cage up and out, up and out. So external intercostal muscle contracts. The rib cage is lifted up and out, up and outward, upside and outward, outside and upward. Okay, that also increases what? That also is increasing the thoracic volume. In which axis? Your rib cage. So everywhere is there. Front also rib cage, lateral side also rib cage, back side also rib cage. So your rib cage is expanding throughout, dorsally also, ventrally also, ventrally front, dorsally back. So I will say thoracic volume increases in DV axis. Thoracic volume increases in dorsoventral axis, DV axis. Are we clear with this? Yes or no? Now, a very important point I am going to tell you. You answer me. You answer me, you will understand this point. Pleura. How many pleural membranes are there? 2 pleural membranes are there. Outer parietal pleura, inner visceral pleura. Outer pleura is attached to what? Outer pleura is attached to what? Outer pleura is attached to thoracic lining, sir. Thoracic lining it is attached. Internal pleura, visceral pleura is attached to lungs, sir. It is attached to lungs. Okay, sir, in between there is a little pleural space. In between there is pleural fluid. There is a negative interpleural pressure that is preventing the lungs to collapse. That was the last point in the last lecture. You tell me, when you are contracting external intercostal muscles, your rib cage is coming out. Your rib cage is expanding, but your rib cage or thoracic cage is attached to lungs also. Your rib cage is attached to lung also via pleura. Yes or no? Your rib cage is attached to lungs via pleura. Yes. So when the rib cage expands, lung will also expand. If lung expands, pulmonary volume will also increase. Many students have this confusion. They understand thoracic volume is increasing. Okay, rib cage is expanding. Array, but that rib cage is attached to the lungs via the pleural membranes. So if you are pulling the rib cage out and up, the pleura is also getting pulled. But when the pleura is getting pulled, the pleura is attached to lungs. So lungs are also getting pulled out. What is happening? Pulmonary volume is increasing. So what I am going to write here, tell me, due to both of this action, pulmonary volume increases. What increases? Pulmonary volume increases. And when volume increases, lung is expanded, pulmonary volume increase. Volume increase, Boyle's law, pressure decrease. Inside the lungs, the pressure will decrease. Intrapulmonary pressure decreases. Intrapulmonary pressure decreases. Are we clear, guys? See, already there is a negative pressure. Please understand. Already inside the lung there is a negative pressure, because pressure as compared to the atmospheric air is less. But when you increase the pulmonary volume, the pressure becomes further negative. The intrapulmonary pressure becomes further lower. There is a huge gradient created now. The pressure inside the lungs is very low as compared to the atmospheric pressure. Now simple physics will be applied, Boyle's law will be applied. Air, atmospheric air, which is now relatively at a higher pressure, due to lower intrapulmonary pressure, air will rush inside. What is going to happen? The air is going to rush inside. क्या होगा बेटा? Atmospheric air will be rushing in, and that's how your lungs will inflate. Lungs expanded, volume increase. Array, you have to fill the air also, na? When air fills, we will say the lungs are getting inflated now. समझ में आ गया? इन्फ्लेट, एयर भर गया. Yes. Now, next. Rib cage is heavy. Rib cage is very heavy, Baba. 12 pair of ribs are there. Sternum is there. You have pulled it out and upwards. External intercostal muscles are feeling the weight of it. So your medulla oblongata stops the signal. External intercostal muscle relaxes. As the external intercostal muscle relaxes, diaphragm also relaxes. Diaphragm is coming up. External intercostal muscle is relaxing. Rib cage is coming in and down, in and down. Your lungs are filled with air right now. So as the rib cage again comes back due to the relaxation of the external intercostal muscles and the diaphragm comes back to its original shape, dome shape, the volume of the thoracic cage is decreasing. Thoracic volume decreases, pulmonary volume decreases, pressure inside the lung will decrease. Your lungs were filled with the air. It's like someone is pressurizing them. Air will be rushing out. So basically during expiration, your intrapulmonary pressure is going little higher as compared to the external atmospheric pressure. The air will rush out. So exactly all these steps will be going in opposite direction. Diaphragm will relax, it will become dome shape. Thoracic volume will decrease in AP axis. External intercostal muscle will relax. Rib cage will go in and down. Up ka hoga down, out ka hoga in. Thoracic volume will decrease in dorsoventral axis. Pulmonary volume decreases, intrapulmonary pressure increases, air will be rushed out. Lungs will deflate. Deflate means air is going out. Am I clear? But all the air cannot rush out. Some air will remain. That we will discuss as residual volume. Are we clear with this? I am not going to write the pathway for expiration. By looking at this, you can make the expiration pathway. I believe this much logic you might be having. Array, yes? Or if you want to waste my time, I can do that, no problem. But I hope you are very smart guys. You can make that pathway again. Are we clear? So you tell me guys. We are talking about normal breathing. In normal breathing, which muscle we used? We only used the diaphragm and we only used external intercostal muscle. So under normal breathing, you are just using diaphragm and external intercostal muscles. Are we clear? Are we clear? ठीक है? हाँ. If you want a little bit more information, you can write breathing is of two types. Breathing, you can write down two types of breathing. One is your, let's say, abdominal breathing. And one is the diaphragmatic breathing. Just hold on, guys. Yeah, too much shouting makes your throat little dried. So I was telling you the breathing types. Two types of breathing is seen. One under resting conditions and one under physical activity, exercising condition. In resting condition, you are doing abdominal breathing, or I will say abdominal breathing is also called as diaphragmatic breathing. It is also called as which breathing? Diaphragmatic breathing. In physical activity, you are doing thoracic breathing. What breathing you are doing? You are doing the thoracic breathing. Okay? Just mention this. So right now you are sitting chill, quiet. Okay? So basically when you are chilling, resting, your breathing is mostly due to the movement of diaphragm. Okay? It's not like the rib cage is not moving, it is moving, but it is not very conspicuous movement. It is not like you can see your rib cage coming up and down. So under resting condition, under which condition? Resting condition, you do abdominal breathing or diaphragmatic breathing. Here your diaphragm is moving more. So more conscious movement of diaphragm is there, conspicuous movement, okay? And here, when you are doing physical activity, in physical activity, you are using more of your rib cage, thorax. Thorax is going too much up and down. So when you can see a person who's doing physical activity, you can literally see the thoracic cage going in and out. So that breathing will be called as the thoracic breathing. You can just remember, in resting, you are doing abdominal breathing. Also, it is called as diaphragmatic breathing. Whereas in physical activity, you are doing the thoracic breathing. Just make a small note of it. Vinuta, abdominal and diaphragmatic is the same, where diaphragm movement is more prominent. Thoracic breathing, more rib cage prominence is there. Okay, that is going under physical activity or exercising conditions, we can say. ठीक है? That's it. Now we can move to the next part. Tell me, what is the next topic we want to discuss? Next topic we want to discuss is the respiratory volume and the respiratory capacities, or the respiratory capacities. Yes, which is the machine we are going to use it? What machine we are going to use it to measure your respiratory volume or capacity? See, under different conditions. Under different condition means you are exercising, you are resting, how much air you can inhale, exhale, hold, the amount of or volume of air you can hold, inhale, exhale under different conditions, that will be your respiratory volume or capacities. And to measure this, we are using a spirometer. What we are using? A spirometer. Using of spirometer is called as spirometry. Spirometrical analysis we are doing. And you get a graphical representation. What you get? A graphical representation. Like when you are measuring the electrical activity of the heart, you are using the machine electrocardiograph. And that PQRST wave, the conducting tissue's electrical activity, you are measuring it. What is that called as? It is called as the electrocardiogram. So similarly, when you are using spirometer, the waves which are recorded, which is measuring your different volumes and capacities, that is what it is called as. It is called as a spirogram. What it is called as, guys? It is called as a spirogram. So spirogram is basically the graph which you see like this. Are you getting me? The graph which you see, that is the spirogram. So there is a difference. The machine will be spirometer and the graph will be the spirogram. Just make a note of this. Okay, everyone. Yes, guys. Have you seen that device during COVID? Many people were admitted with the lung-related issues, and some of them were admitted also in hospital. Once they came back from the hospital, the doctor would have given them one small toy-like device, and red ball, green ball, blue ball. Have you seen that? And the patient, early morning, afternoon, evening, they are blowing that ball, they are pushing the ball. One ball is easy to blow, one ball is difficult to blow. Yes, have you seen that? It's like a small device. 3 containers are there, 3 different ball colors are there, and there is a device where you will blow the air inside this. Yes, do you recall? I can show you the image if you want. That is also the spirometer exercise only. So actually after any lung infection, like after COVID or after pneumonia, the breathing capacity, the volume and capacities are lowered. Now to improve it, doctor gives an exercise where you have to get up, as soon as you get up in the morning, you have to blow the air. First try to blow up the red ball, green ball, blue ball, and every different balls will require more air to be pushed in. So that is improving your respiratory volume and capacity. So why we are doing spirometer? Why you do electrocardiogram? To check the electrical activity of the heart. It can tell us about different cardiac issues. It can tell you about angina. It can tell you about myocardial infarction. Okay, defects in the heart you can detect by studying the waves. Similarly, you can also analyze. You can do the clinical analysis. What you can do? You can do here clinical analysis. Clinical analysis or assessment of different respiratory disorders. For example, have you heard emphysema disease? Have you heard emphysema disease, chronic obstructive pulmonary disorder, or pneumonia? In this, what happens? Your lungs are damaged. When lungs are damaged, so the normal volume and capacity will be affected. So if a person comes to you saying that, sir, I am having breathing problems, breathing difficulties, you will do a chest x-ray or a CT scan to check any anomalies there. Or you can do a spirogram. In this spirogram, you will tell the person, okay, blow the air in this forcefully, normally, and then you record the different volumes and capacities. So actually you are doing the clinical assessment. Okay, then you give some medicine, then you tell them to exercise with that spirometer machine. And then when they come back, if they are having improvement, the volumes and capacity will be improving to normal range. But we should know the normal range, na? We should know the normal range. So basically, here we study two topics. Here we study respiratory volumes, also called as pulmonary volume or lung volumes. You can also call it as pulmonary volume or lung volume. And the another thing we studied, combination of volumes. Addition and combination of volumes will give you respiratory capacities. What it will give you? It will give you respiratory capacities. Which are the respiratory volume which we are going to study? Tell me. There are only 4 respiratory volumes. TV, IRV, ERV, and RV. Yes. Whereas the respiratory capacities, there are 5 of them. Inspiratory capacity, expiratory capacity, functional residual capacity, then your vital capacity, and lastly, total lung capacity. These are the capacities which we want to study. Okay. So for this, we will utilize some slides. So let me open the slide for you. Okay, so let us start. This is the graph which I was talking about. We will discuss this shortly. First, let us discuss the first respiratory volume. Which is the first basic respiratory volume we are talking about? The first basic respiratory volume we are talking about, tidal volume. What is tidal volume? Tidal volume is the most lowest respiratory volume and the most basic of all. Under normal resting conditions, the amount of air inhaled or exhaled under normal inspiration or normal expiration. Like if you are normally inspiring, how much volume of air you will take in? 500 ml. If you are normally exhaling under resting condition, how much you will exhale out? 500. That is called as the tidal volume. So per breath or per breathe, one inspiration 500 in, one expiration 500 out. But If the examiner is asking you per minute value, then you have to multiply the tidal volume with the number of breathing rate. If the number of breathing rate is 12 breathing per minute, last time we told you that the normal breathing rate is 12 to 16 breathing per minute under resting conditions. In exercise, your breathing rate will increase. So if the breathing rate is 12 breathing per minute, 12 into 500, you will get 6,000. 16 into 500, you will get 8,000. So tidal volume per minute, if they are asking you, 6,000 to 8,000 liters per minute. Are we clear? And what is the normal value? Normal value is 500. 500 in, 500 out. Are we clear with tidal volume, guys? Yes or no? Tell me fast. The volume of air inspired or expired under a normal breath. That is a tidal volume. It has the lowest value. A healthy man can take 500 in and 500 out. Okay. Now, some related topic to tidal volume. Okay. You answer me, I will ask you some question. By answering the question, you will understand the concept. Okay. So, we said that under normal condition, the tidal volume inhaled from the nostrils is how much ml we said? 500 ml. Yes. It will reach to alveoli. It will reach to alveoli. But when it reaches to alveoli, alveoli only receives how much? 350 ml. Alveoli received how much only? 350 ml. You inhaled the tidal volume 500 ml. That is your tidal volume. You inhaled through nostrils. But your alveoli received how much? 350. How much is less? 150 is less. Where is the 150 gone? So basically, what is happening is the 30 to 33%. 30 to 33% of tidal volume is not taking part in exchange of gases. Is not taking part in exchange of gases. It is present in the conducting zone. Where it is present, guys? It is present in which zone? It is present in the conducting zone. Do you understand? You have taken 500 ml of air inside. But till alveoli and ducts, only 350 has reached. How much has not reached? 150. Where is the 150? 150 is inside only. But it is in the conducting zone. In the bronchi, bronchioles, trachea. In the conducting zone is there. So actually, tidal volumes 30 to 33% is not taking part in the exchange of gases. It is present in the conducting zone. So roughly if I calculate how much is 30% of 500 ml, that is approximately I will write 150 ml. How much I will write, guys? Approximately 150 ml. So 30 to 33% of tidal volume 150 ml doesn't take part in the exchange of gases. And what is this called as? This is called as anatomical dead space. What is this definition I gave you? This is the definition for anatomical dead space. Anatomical dead space. Sir, why you are telling us anatomical dead space? Because some PYQ is there. And it is a common logic. That you are taking 500, everything will not reach in your lungs. Something will be there in the conducting zone. How much is there? Out of 500, 150 is there. And that 150 is not taking part in the exchange of gases. So it becomes a dead space where the exchange is not occurring. And that is the anatomical structure. So we call it as anatomical dead space. Are we clear with this, students? Are we clear? Yes or no? Come on, give the quick responses, guys. So I will tell you the another space. Another space. Let us talk about another space. Another space is called as physiologic dead space. Another dead space is physiologic dead space. Now, ideally, alveoli and alveolar ducts. Normally, alveoli and alveolar ducts, they are helping in exchange of gases, correct? They are the respiratory zone. But sometimes, some alveoli are defective. Some alveoli are not functioning. They are damaged. Some disease is there, some disorder is there. That alveoli is not taking part in exchange of gas. Conducting zone not taking in the part of exchange of gases, that we understand, because conducting zone, it is meant for conduction, not for exchange. That is anatomical dead space. So what I am saying here is, the part of alveoli and alveolar ducts not taking part in exchange of gases, not taking part in exchange of gases is called as which dead space? It is called as physiologic. Now you tell me, what is the meaning of physiologic? Physiologic means body function. Physiologic means body function. Your alveoli are meant for the body function of exchange of gases. But some alveoli, due to some reason, they are not helping in exchange of gases. So that is a physiologic dead space. Now you tell me, how much percent is the physiologic dead space in your body and my body? Tell me. Anatomical dead space 30%, 30 to 33%, 150 ml. How much will be physiologic dead space? Tell me fast. Physiologic dead space will be how much percent? 1%, 2%, 3%, 4%. How much percent? Guess. In a healthy man, there is 0% physiologic dead space. How much percent? Physiologic. So congratulations. All your alveoli, all my alveoli are working fine. It means, I told you, some 600 to 750 million alveoli, 100 meter square surface area, all are doing exchange of gases. Congratulations. So you and me don't have physiologic dead space. Sir, then why you are teaching? Arey Baba, let's say a person has emphysema. Let's say a person has emphysema. Do you know what is emphysema? Cigarette smoking. Cigarette smoking, chronic cigarette smoking. Cigarette smokers for a very long term, they develop a problem where their alveoli surface area is gone. Emphysema we will study later in disorder, yes or no. So in cigarette smokers, over the long term period, many alveoli are gone. Alveoli are there, but they are not doing the function. They are there, but they are damaged. Surface area is gone. So can I say a person having emphysema will have physiologic dead space? They will not have 0%. They will have little more. It means some of their alveoli is damaged. So a person suffering from alveoli problem, pneumonia, emphysema, some damage is there in the alveoli. That alveoli which is damaged, it is not helping in exchange of gases. That will become the physiologic dead space. So a person with affected alveoli, in them, physiologic dead space increases. So technically speaking, physiologic dead space is a bad thing. In healthy people, it is 0 because our alveoli are functioning normally. Are we clear, guys? Are samjha? Ha, yes, Mukesh. Mukesh in cinema hall. Yes. I hope you got that. ठीक है, chill. Sir, so remember physiologic dead space, anatomical dead space, old PYQs. You never know, like this physics and chemistry, little tough paper is coming. So next year if they make, so you should know the PYQ. This is PYQ related data. Now coming to the next point. After TV, now IRV. Now what we will discuss? After the tidal volume, now we are going to discuss the IRV. Come on. Now we are going to discuss the IRV. What is inspiratory reserve volume? Okay. Under normal inspiration, how much air you can take? 500 ml. Under normal inspiration, one single normal inspiration, you took 500 ml. That is tidal volume. After normal inspiration, whatever forceful air you can take inside, that will be your inspiratory reserve volume. So the amount or volume of air which can be forcefully inhaled after a normal inspiration. 500. After that 500, whatever excess you take inside, that will be IRV. Am I clear? Let us see the definition. What is the definition is saying, guys? IRV, come on. So inspiratory reserve volume IRV is the extra amount or additional amount of air that can be inspired forcefully after a normal inspiration. But I want to update something here. As per the new NCERT, this extra amount of air or the additional word which is given in the NCERT, it is removed. So follow the updated definition. So if you are having the old NCERT, no problem. What you do is you cut down this word. You remove this extra amount or additional word, you remove this. You remove the extra amount or additional amount. You just remember, inspiratory reserve volume is the air that can be forcefully inhaled after a normal inspiration. So after TV, how much you can take more in? Normal inspiration, you took TV inside, 500. What you can take more extra? 2500 to 3000 ml will be your extra capability to take after TV, and that will be your IRV. So value is 2500 to 3000 ml. Are we clear with this? Shall we go ahead? Shall we go ahead, guys? Come on. Arey, give me a thumbs up or whatever, like and all, so I can understand your understanding. Come on. We have to rush now. Okay. Next is ERV. Next is ERV. Come on. ERV. What is ERV? What is ERV? ERV is expiratory reserve volume. Same definition. Little changes. Expiratory reserve volume is that volume of air which you can forcefully exhale after a normal exhalation. In normal exhalation or expiration, you are exhaling 500 ml. After 500 ml of normal exhalation, under normal exhalation, you removed 500 ml exhaled out. Whatever forceful you can exhale after that, that will be your ERV, expiratory reserve volume. See, why we use the word reserve? Reserve is something which may we use or which may not use. Okay? Like if I want to exhale at my maximum, full, then I will use my ERV, no? But I am sitting right now. I am enjoying Siddhartha's class. I am doing normal breathing. Yes, I am not like having a heavy breathing going on. Yes, if you are running on a treadmill and you are listening to my class, you are doing some cardio exercise and you are listening to my class, then that is a different story. Then you are using your EC. But when you are doing quiet breathing, you are just inhaling TV, exhaling TV, inhaling TV, exhaling TV. So you have always the reserve to inhale IRV. You have always the reserve to exhale ERV. Are we clear with this? Are we clear with this? So expiratory reserve volume is the extra amount of air, additional amount of air. This word is deleted from the new NCERT. Okay, that can be forcefully exhaled after a normal expiration. Value is 1000 to 1100 ml. Value is how much? 1000 to 1100 ml in a normal healthy person. If the value is lesser than that, person's tidal volume is lesser than that, it means some problem is there with the lungs. Okay, last one, residual volume. The only volume which we cannot directly measure is residual volume. The spirometer machine will never detect the residual volume. We are taking it as an arbitrary value of 1100 to 1200. So spirometer only detects which volume? TV, IRV, ERV. It does not detect RV. RV we are calculating on other scientific experiment basis like the nitrogen wash. Okay, there are different techniques through which we have calculated the residual volume. And we have said that, okay, we have generalized it, residual volume will be around 1100 to 1200. Are we clear? Remaining three we can calculate. Spirometer tells you TV. So if you are attached to spirometer machine will detect your TV, IRV, ERV, but it will not detect RV. RV is an arbitrary value set 1100 to 1200. By default, it is set. So remember in your mind, out of the 4 respiratory volumes, only first three are measured. RV is not measured directly. So residual volume is the volume of air which remains in the lung after most forceful expiration. So basically, you cannot empty your lungs after a forceful exhalation. So do as much forceful exhalation you want to do. After a forceful exhalation, some air is still left in the lungs. That air which is left in the lungs after a forceful exhalation will be residual volume, and that is 1100 to 1200. Are we clear with this, guys? Are we clear? Yes. So I will give you one interesting example, okay? One interesting relation and clinical application you understand and tell me. So now there is a small chinna pilla being born, okay? One small chinna pilla is born, and we don't know that chinna pilla, that newborn baby, died inside mother's womb or died outside the mother's womb. Unfortunately, the chinna pilla has died. We don't know the chinna pilla has died inside the mother's womb or outside the mother's womb. Okay, some problem occurred. Okay, sorry. So it might have died inside or died outside. We don't know. We were not there at time. How you will check that baby died outside or inside? Was he dead from inside or did he died outside after birth? How you will check that? Take a small X-ray. Take a small X-ray. The chinna pilla, fetus, the fetus never breathe inside the mother's womb. Do you agree? Will a chinna pilla fetus, unborn baby fetus will breathe inside mother's womb? No, they will not. Amniotic fluid hai yaar, they will aspirate the amniotic fluid. So basically the child is not breathing via the nostrils. They are not using the respiratory system when they are inside the mother's womb. So when do they breathe first? When they are born. When they come out and then they draw the first air inside and then they exhale and they don't like it. They are outside, so they cry also. So as soon as the chinna pilla is born, it is crying, right? So to cry, they have to push the air outside. To push the air outside first, they have to take the air inside. So baby, after the birth, they will breathe first time outside. So now if you check the X-ray of the chinna pilla and you don't see any blackening, you know, when you see the chest X-ray, the air appears to be blackened. Yes. So when you look at the chest X-ray of the chinna pilla, you don't see any air. Means the child has not been born outside. It has not drawn the air inside. There is no air inside. So actually the child died inside only. Because if the child had some air, we can understand the child was born out and then he took some air and later might be died due to some complication. But he took some breath. So the first breath or the air we take after the birth. I hope you understand. Okay, are you understanding or gaya sar ke upar se gaya? So, ठीक है, too much complicated. Anyways, we will go ahead. Come on. So it was just like a forensic analysis. It's kind of a forensic analysis. Okay, you don't know the child is died inside or outside. So we are checking the chest X-ray. If there is no air in the lungs, basically they never took the breath and they died inside mostly. Or they didn't breathe also. When they came out, they were born dead actually. And if they were born out, they came out, they took some breath and then they later might have died. So they were taking some air, they born outside and the death was outside the body. Okay. Chalo, next. Respiratory capacity and pulmonary capacity. Respiratory capacity and pulmonary capacity, also called as lung capacity. That is a combination of two or more respiratory volumes. Come on. The first capacity. What is the first capacity? First capacity is inspiratory capacity. What is the first capacity, guys? Inspiratory capacity. So the total volume of air a person can inspire a total volume of air. मतलब maximum volume of air you can inspire after a normal expiration. After a normal expiration. So let's say you completed normal expiration, 500 ml you throw it out. Yes, and then you suddenly pulled the maximum amount of air. So what did you pulled inside? You pulled the TV and then you pulled inside the IRV. So that is TV plus IRV, that will be your IC, inspiratory capacity. So let us look at the definition. Inspiratory capacity is the total volume of air a person can inspire after a normal expiration. Yes, and we have to do this forcefully because first a TV will come normally and then forcefully the remaining air will come inside. It includes tidal volume and inspiratory reserve volume, TV and IRV. Okay, then after this, similar definition as inspiratory capacity, similar definition will be of expiratory. What is expiratory capacity? The total volume of air which you can exhale, the maximum volume of the air you can exhale outside after a normal inspiration. So let's say you completed a normal inspiration, 500 you took inside, now you exhale maximum. When you exhale maximum, okay, what you are exhaling? You are exhaling TV also, you are exhaling ERV also. So this is what? This is your expiratory capacity, total volume of air a person can expire after a normal inspiration. That is the maximum air you are exhaling out. TV plus ERV. Are we clear with this, guys? Yes? Suddenly one question came in my mind. Some question will be asked, arrange the order of respiratory volume in ascending order, descending order. Like if I ask you one question here, if I ask you one question, arrange the respiratory volume in ascending order. Tell me in the chat box what will be the answer. If I ask you, arrange the respiratory volume in ascending order, what will be the answer? In ascending order, you will start from the lowest and you will end on the highest. Correct, hai na? Ascending lowest to highest, descending highest to lowest. Some people do mistake in this also. This year something happened, some people marked the wrong answer. Some ascending descending question was there asked. Okay, I think Amazonian animals and plants number they were asking in that question. So tell me the answer, come on. I asked you the ascending order, arrange me the ascending order of respiratory volume. Which one will be first? Ascending order. Yes, ascending order is from where to where? Ascending order will be from lowest to highest or highest to lowest? Come on. क्या भाई क्या कर रहे हो ऐश्वर्या? Ascending order will be from lowest to highest, beta. Yes. Everyone searching what to press, what not to press. So TV is lesser than RV. RV is lesser than ERV. So 500 lesser than 1100 to 1200 lesser than 1000 to 1100. And lastly, IRV. Tanuja Kumar has given the right answer. Aishwarya, I think you have given the answer for the descending order. Aishwarya beta, you have given the answer for descending order. You have mentioned the highest first and TV the lowest later. Are we clear? So be careful. This question, many students do the mistake. So I just gave you a little bit warning there. Be careful. Next, come on. After expiratory capacity. After expiratory capacity, next capacity. Functional residual capacity. FRC. FRC is the question I have seen year on year. Many students do a lot of mistake. Many students. So see, answer the question. When you do a normal, let's say you do a forceful exhalation. After forceful exhalation, what is left in your lungs? After forceful exhalation, what is left in your lungs? After a forceful exhalation, what is left in the lungs? RV is left. After a forceful exhalation, RV is left. Yes or no? RV is left. Now you tell me, after normal expiration, what will be left? After normal expiration, what will be left? Tell me. You did a normal expiration. What is left? ERV is left, and RV to already is there inside. So after normal expiration, ERV and RV, that will become your functional residual capacity. So remember like this. When you forcefully exhale, RV is left. When you normally exhale, ERV and RV is left. That will become your functional residual capacity. So I want you to pay attention on the functional residual capacity more carefully, because everyone goes wrong in this one. So functional residual capacity is the volume of air that will remain in the lungs after a normal expiration. This includes residual volume and the expiratory reserve volume. Are we clear with this? Okay, next. After the FRC, which one is next? Vital capacities. Yes, Durga Devi, very good. You have arranged for the capacities also. Okay, from the lowest to the highest. Okay, your ascending order you have shown here. Okay, EC less than FRC, FRC less than IC, FRC is. I think IC chalega. IC greater lesser than VC, VC lesser than TLC. Correct. Sahi hai. Next is vital capacity. Sir, once explain how the ERV plus what? How TH? See, Tanuj, not Tanuja. Tanuj, when you normally exhale, you just exhaled the TV. So what is left in the lungs? When you normally exhale, you exhaled TV. ERV is still left. RV to never leaves the lungs. So after normal exhalation or expiration, two volumes are still left. One to never leaves, that is RV. And another one left is the ERV. So ERV and RV becomes what? Functional residual capacity. Am I clear? And when you talk about forceful exhalation, after forceful exhalation, the air left in the lungs will be your just RV residual volume. Are we clear, everyone? ठीक है. Now vital capacity. What is vital capacity? Now vital capacity is a very interesting definition. Everyone knows the formula. Vital means important. So other than RV, all the three things are important. RV is also important. I'm not saying RV is not important. RV is important, but the things you can measure, which one you can measure? You can measure TV, IRV and ERV. You are not able to measure the RV. RV you are taking indirectly. You are taking as an arbitrary value, fixed value, 1100 to 1200. So vital means important. So the three important volumes are TV, IRV and ERV, which are fluctuating. Okay, in a healthy person, it will remain normal. So vital capacity will be TV plus IRV plus ERV. What is the definition? Definition is very interesting. Definition is forceful followed by forceful. Yes, forceful followed by forceful. Sir, but by the Fowler's method, ठीक है, Fowler से कर सकते हो. Indirectly, there are many other methods. Okay, but we normally never calculate the RV value. Okay, forceful followed by forceful. Vital capacity is definition trick. Forceful followed by forceful. So the maximum amount of air which can be forcefully inhaled after a forceful exhalation, or a maximum amount of air which can be forcefully exhaled after a forceful inhalation. Yes, did you understood the definition? Forceful followed by forceful. Sir, volume of air after normal inspiration and forced expiration is the same. No, Baba. See, volume of air after normal expiration is 500. After forced expiration, it is TV plus ERV. Durga Devi, apply logic, beta. After normal expiration, अरे भाई 500 निकाला, only 500 you exhaled. After forceful exhalation, if you are asking, 500 plus ERV. TV plus ERV. So when you are forcefully exhaling, the value will be more. When you are normally exhaling, value will be lesser. But the definition is asking you what is left in the lungs. So when you normally exhale, value left will be more, FRC, TV, ERV. When you forcefully exhale, only RV is left because TV and ERV you have exhaled. Are we clear, guys? Yes or no? Vital capacity, understood the definition? Vital capacity, how you will remember the definition? Vital capacity, how you will remember the definition? Forceful followed by forceful. Maximum amount of air inhaled after a forceful exhalation, maximum amount of air exhaled after a forceful inhalation. The value will be the combination of VC is equal to TV plus IRV plus ERV. Are we clear? Okay, Adi, please write completely what you are saying. ERV also left. Next point, last one, total lung capacity. How much your lungs can accommodate, how much volume of air your lungs can accommodate. So see, after a forceful inspiration, the volume of air accommodated in the lungs after a forceful expiration will be your total lung capacity. So that will be the combination of all the volumes, TV plus IRV plus ERV, and lastly RV also you will add in this. Sir, I mean like RV left in the lungs. Likewise ERV we can measure by the spirometry. Yes, you can measure the ERV. Beta dekho, when you are forcefully exhaling, listen to me Adi, when you are forcefully exhaling, you will get some value. The value of air exhaled forcefully is EC, expiratory capacity. So whatever the EC you got, you remove the 500, left is ERV. Understood? You forcefully, let the patient exhale forcefully in the machine. You got the EC, you got the expiratory capacity. Now from the expiratory capacity, you remove the 500, that is the TV. What is left is ERV. You can measure ERV, bro. Are you getting me? Yes? I hope you are asking the same thing. Okay. Next is nothing. Next is we are completing. Yes, Durga Devi. Total lung capacity is very high. So now we will write some different formulas here. Okay. So what is the formula of VC? Vital capacity we said. Vital capacity we said TV plus IRV plus ERV. Can I modify this little bit? TV plus IRV, I can write EC plus ERV. I can modify it little more. I can write TV and ERV as EC. EC plus IRV also I can write. Yes or no? So just remember what are the different methods of calculating. The examiner may give you different values and may ask you different capacities. Okay? Then similarly, you can also write total lung capacity. Total lung capacity, what you say? All the values are combined here. IRV, ERV plus RV. Now, these first three to is VC. So I can also write VC plus RV. Yes. Or if I combine ERV and RV, that will become FRC. So I can write TV plus IRV plus FRC also possible. Or this value, TV plus IRV, I can again write as IC plus FRC. Are you getting me? So why I am telling you this? So that you know the different combinations of the formula, because examiner may give you anything from this and then you have to calculate the other value. Are we clear with this, guys? Understood? That completes your total lung capacity and their different formulas. Yes or no, everyone? Now, let us look at a small graph. Chalo. Let us try to analyze a small graph. ठीक है? So let's say on the x-axis we are having time in seconds. On the y-axis, let's say we are having the lung volumes, which is mentioned in liters. Right now this is 0 liter. Let's say somewhere here there is 2.5 liter. Somewhere here there is 3.5 liter. So between 3.5 liter, so sorry, I will write here 3 liter. Okay. What is the difference here between, 2.5 and 3 liters? I'm writing the lung volume. Y-axis, I'm writing the lung volume in liters. 2.5 liter, 3 liter. What is the difference here, guys? The difference here, I will say simply, is 500 ml. Yes, the difference is 500 ml or 0.5 liters. Correct. So basically, I can make a graph like this. What this graph represents, tell me. What this graph is representing? This graph is representing the tidal volume. What is this representing? This is representing the tidal volume. So this becomes our tidal volume TV. Yes. This becomes our tidal volume. Yes or no? So the upward wave is inspired tidal volume. The downward wave is expired tidal volume. Upside inspired 500, downside expired. Again inspired 500, again downside expired. Am I clear? Array, yes. So this is one breathing. One breathing. Inspiration, expiration. Inspiration, expiration. 500 in, 500 out. Okay. Next. Next. Let's stretch this graph little above. Let's say this is somewhere here around 5.5 liters. How much is here? 5.5 liters. What is the difference between 3 liter to 5.5 liter? What is the difference between 3 to 5.5 liter, I will say? Here, how much is the difference, I will say? Here, the difference is roughly 2,500 ml. How much is the difference? 2,500 ml. Okay? 2,500 ml is the difference. So let us stretch this. So when this goes up like this and comes down back. So what is this value? From here to here, what is this value? Tell me, guys. From here to here, this value will become what? This will become IRV. Because we have understood that this to this much is tidal volume. This much though was tidal volume from here to here. This much was tidal volume. Above tidal volume, I have inhaled more air, roughly 2,500 to 3,000 ml. 2,500 to 3,000 ml. 6 liter also we can write. This will become IRV. This is IRV. Now you tell me, if I combine both of this, from here to here, what is the blue line representing? Tell me, what is the blue line representing? Blue line is accommodating TV also. Blue line is also accommodating IRV. What this will become? IC. Very good, Akshaya. This will become IC. Inspiratory capacity. Correct, everyone. Now, let us go little bit down. Let us go now downside. Now downside. From 2.5, I will go downside little to 1.5 liter. From 2.5, I will go little downside to 1.5 liter. Let us say till here. Yes. TV is how much? TV is 500 ml. Now let's say from TV, I go to below 1.5. I go below 1.5 from here, let's say. I go down here. Let's say I go down here. Okay. So what is this value? Tell me. What is this value? From here to here, this value becomes what? Tell me. How much difference is there here? 2.5 to 1.5. So I exhaled roughly TV 500 here. I went further down here. That is how much? This is your ERV, by the way. What is this? ERV. The difference between 2.5 to 1.5 here is 1000 ml. And roughly your 1000 ml is ERV. Are we clear? Now you tell me, from here to here, what it will become. What is this whole value? This line represents what? Tell me. It is accommodating the TV also. It is accommodating the EC also. So this becomes which one? This becomes EC. What it becomes? EC. Okay. So basically we did an exhalation. See, downward graph. Always remember, something going down is exhaling. We are exhaling. The graph is going down here. We are exhaling 500. Then we are exhaling 1000 more. That is basically the EC. TV plus ERV, that is the EC. Now you tell me what will be the pink line. Okay, let me show you the pink line now. Starting from up, going till down here. What is this pink line? Starting from up here and going down, it is accommodating the IRV. It is accommodating the IRV here. It is accommodating the TV here. And it is also accommodating the ERV here. So this is nothing but VC. What is this? This is nothing but your VC. So pink line represents the VC. What it represents? It represents the VC. From here to here, I will say. See. I can draw here also like this. This is the pink line. Okay. This is your VC. Now if I go little more below here, below 1.5 if I go, because see, this is 1000 difference. I have to add 200 ml more difference because your residual volume will be little more. It will be around 1.2 roughly, let's say 1.2 to 1.3. Till here what it will become? If I add this one, if I add this value here, later I attach this one, the whole thing becomes what then? The whole thing becomes the total lung capacity. Below ERV if I am going, I cannot go below ERV. Below ERV I cannot go. That is not able to check. समझ में आ गया क्या? See, we are not able to measure RV. This value is RV, by the way. समझ में आ गया? This whole value, let's say till 1.2. Let's say till 1.2 is your RV. RV is not measured by your spirometer machine. It will not be measured. So we are not having that graph included. But yeah, in total lung capacity, if you are asking me, I have to draw one more line stretching from the highest to the lowest. And from 0 to 5.5 liter to 6 liter will be your total lung capacity. Are we clear? Now one last point before closing the lecture. Athletes. Nagi Reddy. Hello Nagi Reddy, 2024 batch. Okay, hello, how are you? Which college you are doing MBBS beta? Now, last point, athlete point. Athletes, everything they have much better as a normal person, as compared to normal person. We studied in body fluid circulation last year that athletes, strokes volume, their heart rate, their strokes volume is higher and their heart rate is lower under resting condition because their cardiac muscles can pump more blood as compared to a normal person. So athletes' lung capacity is also very good. Athletes' lung capacity is also very good. Okay? Sir, 180 in zoology, I texted you that day. Okay, congratulations, Nagi Reddy. Connect me on the Instagram, okay? Connect me. We will have a word. Congratulations. Take care. Very good GMC Telangana, very good college. Okay, I will like to speak more. Connect me on the Insta channel. We will have a little bit word after 9 o'clock. Okay, 9 o'clock my last lecture ends, so we can have a word. Next, what I was talking about last point, athletes. Athletes have a much better vital capacity. Which capacity? Vital capacity. I am not talking about RV. Our vital capacity is TV, IRV and ERV. Okay. But athletes, their value is more. They can hold their breath for a longer duration because their lungs volumes and capacity is more improved due to exercise and training. Are we clear? Last, someone is asking FRC. Someone is asking FRC. What is FRC? Tell me. FRC will be ERV plus TV. So I will just make a line so that you understand. Let's take a bluish line. So where is ERV? Ye wala. See this. From here to here. Do you see this? From here to here, this one will be ERV plus TV. So sorry, so sorry. My bad, my bad, my bad. We are going wrong here. ERV plus RV. ERV plus RV, ये पूरा. ERV, this one. This one is your FRC. This one is your FRC. ERV plus RV. ERV plus RV. Yeah, I was taking EC. I was taking EC, but not EC. Achha, EC also I have not written. So it's not wrong here. We can write this as EC, no problem. But ERV and RV will be becoming your FRC. Are we clear with this? Okay, guys. So again, I will tell you, practice the Gosalites gym booklet, some another reference book, do the PYQs. Okay, so that's it. Still any sir, why sir today evening classes? Yesterday we were having a party. We were enjoying yesterday. Freshers party was there. Nexora fresher party. The next generation's aura Nexora girls fresher party. So we were enjoying there. Okay, late night. So a little bit. All the classes from the morning were shifted in the afternoon. So that we can get little rest and again come back. Okay? So that is the reason. You can go and check out the video. Okay. Okay. So that's it. I will stop here. Okay. Some students are asking for number. I will share my number for your doubts. Okay. You can text me at. I will give you one WhatsApp number. Okay. 9920189372 Dr.Sid11. Okay, wherever you feel comfortable, you can talk to me, no problem. You can share your doubts, anything is there. Okay, we will clarify. So that's it. Thank you guys. Bye-bye. Take care.